Good afternoon. Good evening. I don't know if it's good morning for anyone, but maybe sometime when you decide to watch this, it might be good morning for someone. So I'll say good morning as well. My name's Josh Mailman. I am the inaugural chair of Patient Advocacy Advisory Board for SNMMI. Way back when this was created, 2012, I think we had our first sets of meeting actually late 2011 in Miami, and then we've grown. We decided we needed a chair sometime about 2013, so I picked up that chair. I am a NET patient. It's hard to say that I'm an early adopter of PRRT, but I was someone who needed PRRT very early on in their journey, and long before it was available on, well, long after a clinical trial in the United States had completed on PRRT in 2001 and 3, and long before a new clinical trial would be offered for it, which became the NETTER-1 study. So I traveled to Europe to have PRRT in 2000, actually gallium-68. For those of you, the reason we started a little late is I was giving a tour of the exhibit hall, and we saw gallium-68 or germanium-68 generators that produce gallium-68, which was approved in the United States in 2015. I had my first gallium-68 scan in 2008, and I'm countless ones afterwards, but Thor will talk about the appropriate use of gallium-68. That's not my job, although I authored a paper on it sooner or later at some point. And I did have PRRT in 2009 and 10, long before the trial that would lead to an FDA approval, which was NETTER-1. It's a common misconception on NET patients and even clinicians that PRRT or LU-177 DOTA anything was approved in Europe or elsewhere long before it was in the US. What it was available as compassionate use, and it was really great that I could take advantage of compassionate use. But in fact, the approval for PRRT in the United States, believe came, now my dates could be off a year, I believe it came late in 2016 or around 2016-17, which was really only 6 months behind when it was approved in Europe. It had the opportunity to be approved in the United States before it was approved in Europe, but due to some challenges with data, it took an extra 6 months, and so they weren't simultaneously approved. PRRT, or Lutathera right now, which is the only approved agent for neuroendocrine tumors, we do have AZEDRA, which will be talked about by our second speaker, Dr. Dan Prima. Really are the only two approved drugs for treating neuroendocrine tumors and parapheo in the nuclear medicine space, and so we'll hear a lot about that today. One of the real, the advantages, there are many advantages, and most of them come down to PFS or progression-free survival, which is fantastic, but from a patient, and that's my role here, is give a little bit of a patient perspective, and we'll only have 2 speakers, so we'll be doing fine today as far as timing. From a patient perspective, PRRT is a really kind of simple drug to receive as a patient with minimal side effects, very high quality of life, some challenges with some various different side effects, but Dr. Thor will talk about that. And so there are now over 225 centers in the United States that offer Lutathera. We were just at the company who produces AZEDRA, I-131 High Energy. There are much fewer centers that actually produce or administer AZEDRA. So there's still lots of open questions. Dr. Thor and I don't know if you'll bring it up on your slides. I don't think you did because I looked at your slides. We authored a paper together right before the pandemic when we thought people were traveling a lot. We finished a paper that got accepted for the March, actually it's the April 1st or April 2nd edition of the Journal of Nuclear Medicine back in 2020, which was understanding what patients should know about and healthcare providers about traveling after therapy with LU-177. And we worked with colleagues, other colleagues in Mayo and Homeland Security to put that paper out. Putting out a paper on travel a month later could go into the comedy sketch we heard about an hour ago, but it still is a highly regarded, and now we're back to traveling again, so the paper doesn't change, but it was comically timed, so to speak. So with that, we have two guests today. Both are friends. As I said, Dr. Thor Halfdannersson is someone I work with and have written papers with and am on steering committees with on various different topics on neuroendocrine tumors and on various different study drugs from the Mayo Clinic. And our second speaker will be Dr. Dan Prima, who I've worked with for I don't know how many years at this point, but has given talks and helped understand the patient perspective for many years that we worked together on different projects for the Society of Nuclear Medicine and with his colleagues at the University of Pennsylvania. And with that, I'm going to shut up until it's question time, and then I promise to probably ask more questions than Thor or Dan want to have. But I look forward to seeing you asking questions in the YouTube feed. And also, when you're here, you can just come up to the microphone when we're done. Hopefully, we'll have plenty of time for Q&A, networking, and discussion. So with that, I'd like to, apparently our first speaker is Dr. Thor, just looking by what's on there, and give him a round of applause.
Thanks very much. So thanks again for inviting me to speak. So I will be talking on advances in neuroendocrine tumor diagnosis, therapy, and treatment. So I won't spend a lot of time on like individual treatment for neuroendocrine tumors. I wanted more to spend some time on the big picture, how to approach a new diagnosis of a neuroendocrine tumor, when to seek another opinion, and things of that nature. So these are my disclosures. So these are my objectives. So brief overview of neuroendocrine neoplasms, including classification and epidemiology, and what do we mean by grade, differentiation, and stage, and then how do we diagnose neuroendocrine tumors, and then wrap up with treatment. So what are neuroendocrine neoplasms, or NENs? So we used to call them NETs, and now we call them neuroendocrine neoplasms. And it's a very confusing terminology, and I'm hoping to explain some of that to you here. So neuroendocrine neoplasms is really a collective term of a very different, like whole like family of very different and very unique tumors. So a NEN stands for neuroendocrine neoplasm. A NET stands for neuroendocrine tumor, which tends to be much less aggressive than the NEC, which is a neuroendocrine carcinoma. So this nomenclature is very unique in oncology, and to many oncologists doesn't really make a whole lot of sense. And but it's a system we're stuck with for the time being. So what is a neoplasm? A neoplasm is really an abnormal mass of tissue that results when cells divide more than they should and don't die when they should, and start going places they shouldn't go. And tumor is essentially the same definition, but not for neuroendocrine tumors. A neuroendocrine tumor is a lower grade, slower growing tumor. A neuroendocrine carcinoma is a faster growing, more aggressive disease. And that's the one with the ability to invade other organs and spread. So where do NENs, neuroendocrine tumors or neuroendocrine neoplasms come from? So they can arise almost anywhere in the human body. I don't think there's a part of the human body I have not seen it in yet. And so most typically the small intestines, pancreas, rectum, lungs, and they are extremely heterogeneous. So you can have among the slowest growing neoplasms or tumors in man, you can, there are some patients I have followed now for more than 10 years, and we haven't really given them any therapy at all. just watch the tumors grow very, very slowly. And then there are others who need therapy within days of diagnosis. So you have to figure out who needs urgent therapy and who can wait. So, and how common are the NENs? Is it really worth having a whole session, a whole day about the neuroendocrine tumors? And I'll make a case that it actually is. So this is a paper from 5 years ago. This is looking at a US database of cancers in general. So it's called the SEER database, or Surveillance, Epidemiology, and End Result database. It captures about 28% of the US population. And what I want to show you here is that on that graph there, if you see that blue line, that's all cancer. So cancers were getting a little bit more common, and then in like the early 90s, we saw sort of the peak cancer. After that, we started seeing new numbers of cancers in general dropping, partly because of lifestyle choices, less smoking, and also probably increased screening. But if you look at the yellow or orange line, those are the neuroendocrine tumors, obviously on a very different scale. You can see they went from being fairly uncommon in 1973 to being pretty common in 2012. And this is a 7-fold increase since the early 70s. So we see this in all of these neuroendocrine tumors, and I'll show you some more slides there. So I wanted to explain a couple of concepts for you. One is what's called incidence of tumors. Incidence is really the number of new cases over a given period of time. So you could think of that, how many new neuroendocrine tumors in Chicago in 2023, and that would be the incidence of neuroendocrine tumors for Chicago. And prevalence is a different number, tends to be much larger, and in the case of neuroendocrine tumors, a lot larger than incidence. These are the patients who are living with the disease or have had the disease diagnosed. And because many neuroendocrine tumor patients live so long, the prevalence can be really high. So we're seeing this increase all over the different anatomic origin of those tumors. Look at, for example, the lungs. From 73 to 2012, substantial increase in small bowel neuroendocrine tumors. In rectal neuroendocrine tumors, I think that's mainly because we're doing so many screening colonoscopies that we're picking up these tumors that probably went unnoticed and sometimes people probably died of old age without knowing. And then pancreas, which is a particular research interest of mine, and that's almost entirely explained by more scans that we're doing for other reasons. Well, so we would say, well, it's probably US. We're like crazy with imaging. Everyone's getting CT scans at all times. And well, let's look at another system, which is very different, which is the system in the UK. And here we can see the same. So lung, we can 400% increase, and this goes back to 95 from 2018. The pancreas, 700% increase. We're seeing exactly the same curves. They look just like the curves from the US. And I could have shown you a paper from Norway just a month ago, exactly the same. And I could have shown you papers from Japan and Taiwan and other places. This is really everywhere, all over the globe. So why is that? So I think some of this, probably much of this, is just more scans. So now if you have, if you slip on ice, as we tend to do in Minnesota, and you go to the ED, you have you're going to have a CT scan. So because they're going to look for like blunt trauma and whatnot, and they find a small tumor in the pancreas. If you have a kidney stone, instead of having a plain X-ray, you're going to have a CT scan now, a non-contrast CT scan, and you might find something. So you're getting all of these CT scans for other reasons, and you're finding stuff on them. And I think there's also a better awareness among healthcare providers and patients. And then even if we account for that, I think there's also some like real increase, and I don't know why. And so moving on, so to a few more concepts here. So tumor grade and differentiation. So these are incredibly important, especially as we hear more about the PRRT and selection of therapy. So the behavior of neuroendocrine tumors varies greatly from one person to the next. So they can be, as I said, very slow growing to extremely fast growing. And we have this system called the tumor grade. And this is just a way to look to see how a tumor may behave over time. We have the grade 1 tumors that move very slow, and we have the grade 3 tumors that move very fast. But then there's a lot of variability within grade 3. Some of them actually don't move that fast. And so the tumor grade is really a system to allow us with some certainty to predict what's going to happen in the future. So, and what we do typically in practice is to take a piece of the tumor, stain it with a stain that's called KS7 or MIB1, and this stain, it's just like paint, sticks to the cells that are actually dividing. And then we count the number of dividing cells, and we get an idea about how many of the cells are resting and how many of the cells are growing. More growing cells, more dividing cells, more aggressive tumor. And this really predicts outcomes in terms of life expectancy, chances of tumors coming back after surgery, duration of treatment response, and so on and so forth. And probably trumps pretty much every other predictor out there. So this is how it looks in practice. So on the left-hand side, you can see that there's a sort of sea of blue dots with occasional brown dots. So these are the KS7 positive cells. As you move over to the right side into the grade 3, you see almost all of the cells are now staining brown, and that's more aggressive. And the tumor grades, grade 1 is less than 3%, grade 2 is 3 to 20% KS7, and then grade 3 is more than 20. But 21, a tumor that has 21 is not the same as a tumor that has 99. So that's actually where things get a little interesting. So, and that's where we get into differentiation. So what is differentiation? So differentiation is really how much do the tumor cells resemble the normal cells that they derived from. And this is it's a really tricky call because you really need an experienced pathologist that has been looking in the microscope for a long time to really get this right. So do the cells look sort of all the same, bland, well-behaved, or do they look aggressive? And so sometimes you should be, just by looking at the pictures, you're able to spot which of these animals is an immediate threat to your life and health. And my wife, who's a pathologist, so she sometimes says, she looks in the microscope and she says, these are cells I do not want to meet in a dark alley at night. So, and immediately you can sometimes tell. And so moving on, so where it gets a little tricky though is that with grade 3 neuroendocrine tumors or neuroendocrine neoplasm, you can have neuroendocrine carcinomas or NECs and neuroendocrine tumors. The tumors are much better behaved than the neuroendocrine carcinomas are, although they are all grade 3. But the grade 3 neuroendocrine tumors are still worse behaving than grade 1 and grade 2 neuroendocrine tumors. So stage, one slide on stage, so I get this question quite a bit. So stage 1 and 2 is limited to the organ it started in. For this example, the colon, it's from actually a colon cancer slide I saw. So stage 3, now it's into the lymph nodes nearby. Stage 4, it has gone from the organ it started in into different organs of the body. So what are the symptoms of neuroendocrine tumors? Let's take a look at that. So the symptoms can be very, very nonspecific. There are a lot of studies out there looking at the delay from symptom onset until diagnosis. And it's not uncommon to have someone who's had symptoms for years, even for a decade. Years ago, when I was at the University of Iowa, I had a relatively young person then he was probably in his mid-30s, who presented with right-sided heart failure and carcinoid heart disease. And when he was a college student, he used to flush a lot when he drank alcohol, to the point that it was almost like a party trick. So he would have a glass of wine and he would get like really fiery red. And then 15 years went by until he developed carcinoid heart disease. He almost certainly had metastatic neuroendocrine tumors when he was in college, without knowing, and had carcinoid syndrome. So sometimes with the high-grade neuroendocrine carcinomas, things happen much, much faster, sometimes pain from tumor growth and the tumor bulk. And then we have the fascinating but relatively uncommon functional tumors that produce hormones that can drop your blood sugar, cause severe like reflux and skin rash and so on and so forth. So we don't have time to talk about those, but those are very fascinating. Oh, let's actually go back here one slide. So this is the carcinoid syndrome. So on the left-hand side, you see that gentleman with that sort of red flushing there. And this is incredibly dynamic. I was in the clinic 2 weeks ago, and I was sitting there with a patient who was flushing, and literally within seconds he flushed. And then it lasted maybe 30, 45 seconds, went away. And then you can sometimes trigger this by pushing on their abdomen. If there are like large abdominal metastases, you can just push on the abdomen, and you will find flushing. Just because by doing that, you're releasing some of those hormones into the circulation. On the right-hand side, we see here, if this works, this video, you can see that vein that pulsates here in the neck. So this is someone with carcinoid heart disease. And this is one of those things that you can sometimes just pick up in the clinic. This week, or actually last week, So last week I was in the clinic seeing a new patient I've never seen before, and her veins are like really bulging, and I don't know yet if she has carcinoid heart disease, but she's getting an echocardiogram tomorrow. So you have to look for all of these subtle signs of the disease. So into the diagnosis then. So now you suspect that there's a neuroendocrine tumor. How do you go about diagnosing this? So we need a biopsy of any tumor to really make the diagnosis. We can almost never make a diagnosis without a tissue sample. We do it for some cancers, but not for neuroendocrine tumors. So you need a really good pathologist, because if the pathologists get the diagnosis wrong, everything you're going to decide, or a lot of what you're going to decide on after that, is going to be incorrect therapy. So this actually is one of the arguments for neuroendocrine tumor centers. So about 20 to 30% of biopsies are actually, the diagnosis is changed once it's read at a high volume center. So whether that really changes the treatment all that much is another story. But just this last week, there was a paper from Italy looking at how often the diagnosis changes when you get diagnosed, let's say, by your home team, and then they send the sample to be looked at by an expert pathologist. They change the diagnosis. And sometimes it makes no difference. The treatment's going to be the same. Sometimes it really drastically changes everything. So good imaging, and we'll hear more about that. So without pathology and without radiology, I am totally blind. I have no idea what I'm doing. And so we need really good imaging. In the clinic, the CT is still the workhorse that does most of the work for me, but you have to do it really well to get the most information out of it. There's a lot of bad CTs out there, and the neuroendocrine tumor CT you have to just be really careful when you do the CT in terms of timing the contrast, and I'll show you some pictures there. If you're really looking at the liver, I like MRI, and even MRI with certain types of contrast that allows me to see things in the liver maybe better than I would with any other scans. And then we have PET imaging. So somatostatin receptor PET, or SSTR PET, which we sometimes call dotatate PET, or gallium-67 or copper-64 PET, and now I'm just trying to always call them somatostatin receptor PETs. These are incredibly important scans, and but don't really are not really needed for all neuroendocrine tumor patients. So for example, with the patients with the high-grade neuroendocrine carcinomas, you may not need a dotatate PET, but you need another type of PET scan called FDG PET. So this is just to show one of my patients here. So on the left-hand side, we see this is a gallium-68 dotatate PET, and then we have a CT scan, and actually the CT scan, so those 4 images to the right, this is all the same scan. It's just done within a few seconds or within like 30 or 90 seconds of each other. And if you look at those dots, you can see those slightly white dots in the arterial phase, and you can see some of them in the venous phase, much harder to see, and they actually correspond to the red dots on the PET. So on this here, it's the same patient, just a little bit further down in the liver, or further up, actually. It's so you can see that we can see the red dots we see on the PET, we can see on the arterial images, but when you look at the venous images in the far right corner, we can't see anything. And I have seen patients come in with livers that are chock full of tumor, which you could barely see anything on what's called monophasic CT. So you have to be really careful. But then the defense of the people who do the CTs on the outside, when you have that initial CT, they are not looking for a neuroendocrine tumor. So they are not protocolizing that study to look for a neuroendocrine tumor. But when we see them in the neuroendocrine tumor clinic, they all come with the diagnosis of a NET, and we can do this to maximize the information from the scan. So another thing I show to my patients is that on the PET scans, the tumors often look a lot larger on the PET than they do on the imaging. So if you look at this here, so this little round dot, this is the right kidney, left kidney, that's a pancreatic neuroendocrine tumor. That looks pretty big to me. So when you look at the MRI, that's it. So this is one of the reasons we can't use PET scans on clinical trials because we can't really accurately measure size. So you need anatomic, contrast-enhanced anatomic cross-sectional imaging, as we call it. But the PETs are still incredibly helpful. Just a few more PET studies here. So this is one of my patients with a very slow-growing tumor. This is 2019, 2021, 2 years. Now we could see widespread metastatic disease. But this actually was a lower-grade pancreatic neuron tumor, and this person was entirely asymptomatic. But we would not have there are some tumors in the liver, but I would not have appreciated the progression here had I not done a PET. So this led to us talking about PRRT, and then the patient eventually having a PRRT and doing really well. So I would not have picked up on this on a regular CT, maybe on an MRI, but not on a CT. And so these are just a few of the unusual neuron tumor metastases we see on somatostatin receptor PETs, sort of in the top. I don't think I have a pointer here. So anyway, so the top left would be a metastasis to the breast. We actually see this surprisingly often with patients with small bowel neuron tumors. Brain metastases, that's on the right top there, are not that common. Orbital metastases behind the eyes, not that uncommon, and sometimes manifest with double vision. And then we're finding more and more cardiac metastases, and they're just sitting there quietly in the heart, never cause any problems. We actually looked at this at Mayo recently. None of our patients we found had any cardiac issues, but they can just have these cardiac metastases. So moving on, so when do we use PET imaging? So there are guidelines that are really helpful. And for me, it's sometimes the question is of when is the SSTR PET critical and when is it just helpful? So guidelines can never capture all scenarios. So sometimes you're ordering a PET scan, which is not necessarily by any guidelines, but it's just very important for you to make the right decision for that patient. And so that's what we need to get insurance sometimes to understand, is that the guidelines are not like black and white. So there is a lot of gray there and a lot of what I call the art of medicine. But typical strong indications would be like initial staging, planning PRRT, looking for a primary tumor, planning surgery. You want to know what you're getting into, and then monitoring of patients with metastases that are hard to see with other imaging like bone metastases. This is just to show you one of those guidelines documents. I'm not going to walk you through this, but these are several, like 13 different scenarios with appropriateness score. So these are all helpful, and these are the papers I actually use for insurance companies when they turn down a PET. So I said, well, look at that line number 6 and for this patient, and they often come around and say, oh, actually, you're right. It's not in our guidelines, but it's in these guidelines. Okay, so moving on to therapy. So I was just diagnosed with a neuroendocrine neoplasm. What should I do now? So these are my rules for addressing any new cancer in my clinic. So my first question is always, did I get the diagnosis right? Do I have a pathologist I trust who has signed this out? Have I done all the necessary workup? Did I order all the appropriate scans? Have I staged this malignancy correctly? Do I have all the labs I need? What is the intent of the therapy? Are we talking curative therapy, surgery, be done? Are we talking prolonging life? Are we talking controlling symptoms? And it can be sometimes more than one goal. And then obviously, what are the patient's goals and expectations? And be honest. We know with current treatments a lot of times that we will not be able to cure that patient. And it's better you should tell them up front. And that this is not a curative situation with our current treatments, but maybe in the future it will be. So ask your doctor these questions. So what's your experience? It's a rare tumor. I think it's fair to ask. So, even the busiest oncologists may not have much experience with this. And ask them, are you sure? Do we have the correct diagnosis? Are there any more tests? And should I seek out an expert in management of NENs? And that's very important. And if I get an expert opinion, are you willing to work with that person? And if they say no, that's when I tell my patients, you should probably find another oncologist. So because we need to get together a team. So the role of the NET Expert Center, we talked about the correct pathology and things like that, and we changed the diagnosis. But it's also, we don't need to see you at any given time point. We need to be available at crucial time points where something is changing. So I will say a lot of the oncologists out in the community are fantastic net doctors, and I always prefer teaming up with them if I can. And most of what I recommend can actually be done well in the community. And, but there are certain things I might have. I might have a trial or a specialized procedure or maybe some fancy new imaging or scan that they don't have, and that might be a reason to come see me. And then we have tumor board discussions, and where we actually sit down and discuss challenging scenarios and things of that nature. So into the treatment, so that's the final section of my talk. So why do we treat NET? So we have two main goals. So to relieve symptoms such as the carcinoid syndrome, symptoms of bulky metastases like pain and things like that, and functional syndromes like low blood sugars and whatnot, and to prolong survival or life expectancy. And not all treatments have been shown to prolong survival. And just be mindful of toxicities as well. It's pretty easy to harm someone with therapy. For me, it's always the easy way out is to pick a treatment and say, hey, we're going to do this, but it might not be the right thing to do, but it might be the easiest thing out for me that day. So be very mindful of that, as well as financial toxicity, which is very, very real. And and don't forget, this is not one size fits all, so you have to look at every individual. I will say that no two neuroendocrine tumor patients are the same. So things to consider before starting therapy is, do you really need to treat? And a lot of times you don't. And I'm actually following a lot of patients who've never seen any therapy with metastatic disease. And then where did this start? Because if it started in the pancreas, you have other options than if it started in the small bowel. And then obviously states on differentiation and grade. So be really careful at considering the patient and tumor characteristics. So what may be appropriate for one person is not appropriate for another. So let's say you have someone who would be a really good candidate for everolimus or Afinitor, but has really bad diabetes. Well, you might want to do something different because everolimus will affect the blood sugar control. Same thing with sunitinib in someone who has really bad hypertension. You might not want to do that, at least not yet. And then consider the financial toxicity, and then in younger women and men, reproductive toxicity, which is not a big typically not the big topic, but comes up in the clinic every now and again. And then the long-term toxicities of treatments like leukemia from PRRT, which is rare but real. So why tumor board? So I've said that the tumor boards you should use sparingly and for patients where you really need help. And so we have multiple different specialties. So the NET tumor board at Mayo is every other week, probably like 30 people there, 5 different surgeons, nuclear medicine, radiology, interventional radiology, everyone's there, pathology is there, and we discuss the really challenging cases there. So we can't discuss all of the cases. We see 500 new neuroendocrine tumors at Mayo a year, and there's no way we can present every one of them at any time at tumor board. So we really have to pick carefully, and tumor board is incredibly helpful. So into specifics of therapy, so for treatment of symptoms, we have the somatostatin analogs, octreotide and lanreotide. They're probably equally effective. And then we have drugs for symptoms, and this is probably, I know that this is a little bit outside of the scope of nuclear medicine, but I see a lot of patients come to me with refractory carcinoid syndrome, so with refractory diarrhea from carcinoid syndrome. A lot of them have pancreatic exocrine insufficiency from the injections, and they need creon or other digestive enzymes. A surprisingly high number of them has what's called bile acid diarrhea. They've lost a portion of the small bowel, and now they have really severe bile acid diarrhea, and they need bile acid binding drugs. So you have to be really careful with when you take a history, and especially in terms of their symptoms. So what about the different modalities? We talked about the observation, we talked about surgery. We have some really interesting recent data on aggressive liver surgery for patients with metastatic neuroendocrine tumors. We haven't shown conclusively that going after these aggressively with surgery prolongs life expectancy, but we're seeing that in our metastatic patients with or patients with metastatic pancreatic and small bowel neuroendocrine tumors who have liver metastases, if we aggressively resect the primary tumor and the liver metastases, we're looking at life expectancy of 10 years or more, which is longer than we have seen in any of those recent clinical trials. But that obviously is that now we're starting the clock at the first diagnosis, not starting the clock at the progression on somatostatin analogs as was done on the PRRT trials. We have to be mindful of that as well. And then we have all sorts of non-surgical treatments. We're using much more ablation and focal radiotherapy, so very targeted radiotherapy. And just last week, there was a really interesting paper from Germany looking at the usefulness of that. And then the medical therapy. So substantial advances in medical therapy in the last 1 to 2 decades. We won't go through all of those advances, but the somatostatin analogs are the first choice for most of our patients. There are some really cool new somatostatin receptor-directed treatments out there. So one is an oral drug called paltusotine. Another one is a subcutaneous octreotide that gives much higher blood concentration than the regular octreotide called CAMP 2029. Then obviously targeted therapy with everolimus, sunitinib, and others. And then the PRRT, which we'll hear more about from the next speaker. And then one rare one I wanted to mention, belzutifan. So for the rare von Hippel-Lindau associated pancreatic neuroendocrine tumors, this is an incredibly effective drug, but it's a very rare disease. Okay, so PRRT, this is my only PRRT slide, I think. So how does PRRT work? So this is what I use to explain this to my patients in the clinic. So you have your neuroendocrine tumor cells. It has the somatostatin receptors on the surface that code to the tumor cell. So to make PRRT work, we need the target, which is the somatostatin receptors, those little blue dots around the cell. So that needs to be present. We confirmed that with an SSTR PET study. We need something that binds to the receptor, like a somatostatin analog. We need a therapeutic radionuclide, something that delivers lethal radiation to the cell, and then we need a glue to keep this all together, or a cage, so this just doesn't fall apart the moment you inject it into the patient. So you inject this, you let this float around in the system, and the treatment there, in this case, the lutetium-177 dotatate, it sticks to the tumor cells like 2 pieces of Velcro, and delivers the lethal radiation to the cell, and that's how you get the treatment effect. And we have really only one approved radionuclide now, which is lutetium-177. We have yttrium-90, that's been used in the past. We don't use it in the US much. And then we have the alpha particle PRRT coming, which is really exciting. So where does PRRT fit in? So obviously only for those who have the target, the somatostatin receptor. Typically not as first-line therapy, at least not yet, but those trials are being done and have been done, and we'll have some more information on that soon. So this is appropriate for multiple different types, so pancreatic, small bowel, lung, and others, and can be incredibly effective at controlling symptoms of functional tumors. We've had patients with refractory hypoglycemia because of insulinoma, metastatic insulinoma, with complete normalization of their blood sugars within weeks of getting PRRT. So this, I think, is my last slide. So how do I think about this? Well, it depends on the anatomic origin. So if we have a small bowel neuroendocrine tumor, I start with a somatostatin analog. If you have to start with anything at all, that is. Once there is tumor progression, we have PRRT or everolimus. I would gravitate towards PRRT because it's a much more effective therapy, but everolimus is still a good choice for many patients, but not all. And then beyond that, we have the kinase inhibitors and clinical trials, and we don't really have a whole lot of therapy beyond somatostatin analogs, PRRT, and everolimus, and this is where we really need help. So we have clinical trials, and then we have the alpha particles coming, the retreatment with PRRT, interferon, even chemotherapy. So that's small bowel. So this would be pancreatic neuroendocrine tumors. So here you can start with a somatostatin analog. It's always a good start. Unless you really need to shrink things down, you can use CAPTEM, and should actually modify these slides to add PRRT here, because PRRT actually works at shrinking tumors down, but might be a little bit more hard to get approved. And then if you have both functional and large tumors, you can use both a somatostatin analog, CAPTEM, or PRRT. I really should modify these slides. So then beyond that, you have PRRT, everolimus, sunitinib, and capecitabine and temozolomide, chemotherapy. And then you sort of, if you have a functional syndrome, I would do PRRT. That's where I have had really good luck. And then you sort of cycle through the option until you've tried everything, and it's time to look for something new. And we don't really know what is the ideal sequencing there, but that's being tested now. And then we go into the clinical trials, the kinase inhibitors, so cabozantinib, lenvatinib, surufatinib, and others, and possibly we can sort of cycle through those as well, we just don't know. And then we have the other options, most importantly, clinical trials. So that takes me to the end of my talk. Thank you very much. Are we going to do questions right after this, or?
Yeah, why don't we'll do questions together? Yeah. Go for it. Thank you.
Thank you.
Where is that, the computer here? All right, we're going to hope for the best because there was an error when I pulled it up, but we'll see. Thank you very much for the opportunity to be here. It's really exciting to have this, this chance. Always good to interface with patients both in the room and online. And I'm just going to be talking a little bit about the nuclear medicine side of things with NETs. So there are a lot of modalities that we use in nuclear medicine. You got a little taste of that earlier, but just to go into a little bit more, we have what we call single photon imaging. So these are isotopes that are releasing single photons of radiation that we can image with what's called a gamma camera. PET imaging, we have therapy, and they all involve administration of a radiopharmaceutical. So it's makes the question, what is a radiopharmaceutical? And very simply, it's a drug that is radioactive. And so these are typically systemically administered. Usually we give them IV most of the time, but not always. And there are the three components. There's the targeting component to deliver it to where you want to go. There's the isotope for either imaging or therapy. And then the drug component itself is kind of the whole package. And the first step to getting radiopharmaceuticals approved is showing that there's really, you're giving them in such small amounts that there's no drug effect. So this isn't like when we talk about you take ibuprofen 200 milligrams, with most of these things we're giving like picogram amounts. So thousands of times less and very little drug effect or none at all. There are a lot of approved radiopharmaceutical diagnostic agents. You heard a little bit about gallium dotatate, copper dotatate, gallium dotatalk, FDG, MIBG we'll talk about a little bit today. There's a bunch of other things. In fact, there's a whole meeting here for 4 days about all these other agents that people are working on. So the sky's the limit, but most of them have limited relevance to neuroendocrine tumors. But you'll hear about some of them the same way that we used to have indium pentatriotide or actrioscan, and now we use dotatate PET scans, working on MIBG analogs to try to switch MIBG to a PET scan, which should hopefully be an improvement. There are new somatostatin agents out there. FAP you may hear about is kind of the hot target lately, but probably will play a lesser role in neuroendocrine tumors. Similarly, there's a lot of therapeutic radiopharmaceuticals that are FDA approved, and this list has really expanded in the last 5 years. So we had in 2018 was a good year with both dotatate and MIBG were FDA approved as therapeutics, and then since then we've had PSMA added, and we have quite a few. And the ones in bold here are the ones that are most likely to be used in neuroendocrine tumors. On the investigational side, you already heard a little bit about alpha PRRT. I'm going to cover that a little bit at the very end. There are other variants with lutetium-177, and then a whole bunch of other things. So single photon imaging, again, this is where we're talking about isotopes that release an individual gamma rays when they decay. And you can either do planar imaging, so two-dimensional imaging like a photograph where you're taking a picture except you're seeing everything from the insides as well. Or you can take a bunch of those images from multiple angles around it, and we call that SPECT, single photon emission computed tomography. And it just allows us, when we take pictures from all bunch of different angles, we can reconstruct that into a three-dimensional image. And the most common ones for neuroendocrine tumors are indium-111 pentatriotide or actrioscan and MIBG scans. The pentatriotide scans have been completely replaced by dotatate PET scans. And if you're in a place where they still want to do an octria scan, you should go somewhere else. This used to be a much bigger problem, but over the last few years, it's really, really improved. And especially with copper-64 dotatate, it has a much longer half-life and can be shipped pretty much anywhere in the country. And so that really takes that problem away. So most of the time, if you're getting a single photon scan, it's going to be an MIBG scan. And very briefly, the way a gamma camera works is you first have this big hunk of lead called a collimator that blocks any photons of light that aren't hitting it straight on. And that's a way to kind of focus the images. And so you can imagine most of the photons aren't hitting it straight on and making it through. And so you have a lot of decrease in sensitivity. So of all the photons coming out of the patient, you're only detecting like 1% of them. It's a very small fraction. And so because of that, the images, nuclear medicine used to be lovingly called unclear medicine. So we'd see kind of these blobs in space, and it's sort of like a face only a mother can love kind of thing. I think they're quite beautiful images, but that's part of it, is we just don't get a lot of signal that then hits this crystal that turns that high energy photon into visible light that then the electronics of the camera can turn into an image. And so this is what a typical SPECT camera looks like in practice. You have these two gamma cameras. They're going to be above and below for planar images, but then for SPECT they rotate around. And then behind it, this is a CT scan so that we can overlay the single photon imaging, the nuclear imaging with the CT scan, so we can tell where in the body those things are coming from. Now, most people think about gamma radiation as the thing that turned the mild-mannered Dr. Bruce Banner into the Hulk. And I know patients really worry about the radiation doses they're receiving for their scans. And the one thing I can tell you is we worry about this as well. There have been some pretty alarmist theoretical studies over the years that have been published talking about how many cancers are caused by diagnostic imaging. We need to balance that against the benefits. And I can honestly say I've never seen a patient in my career where I can say realistically that their diagnostic scans cause them harm from the radiation exposure. But there are thousands of patients who have clearly benefited. So we don't do scans willy-nilly. We try to stretch them out whenever possible. We pick things like MRI because it has no radiation exposure. So if that can answer the question, we do that preferentially. But the risk-benefit ratio is really, really lopsided. So I just want patients to not be too afraid of the scans, because you're so much more likely to benefit from them than have any harm. And this is something that is worth talking about. And if someone's getting, you're having scans every 6 weeks for the last 10 years, that's probably something to talk to your doctor about. But most of the time when these things are done over a long period of time, they're almost certain not to harm you, and they're very likely to benefit you. And so I'm going to start talking about MIBG a little bit. It is a drug very near and dear to my heart. This is where we are celebrating at Penn the FDA approval for MIBG therapy. It was first published in 1980 as a diagnostic agent, didn't make it through as an approved therapeutic until 2018, reflecting the rarity of the disease and the difficulty of getting these things done. These scans have changed quite a bit. They used to be the sort of #1 nuclear medicine scan we did for patients with pheochromocytoma and paraganglioma, and in some cases also with other neuroendocrine tumors. In these normal scans, you see the salivary glands and some activity from the saliva and the nasopharynx. You might see the thyroid gland, because a little of the radioactive iodine can break off and goes to the thyroid. We'll see the heart and the liver and the bladder. And this is a normal scan. Whereas on the flip side, an abnormal scan in a patient with paraganglioma, that's the primary tumor there in the belly. And then you can see these spots that are very faint, but they're in the bones. And we know that that's never normal with MIBG. And so these are bone metastases that are very, very difficult to see with any other imaging modality other than these MIBG scans or dotatate PET. A little bit of a spoiler alert, dotatate PET has really replaced MIBG scans across all neuroendocrine tumors, including pheochromocytoma paraganglioma, as the primary functional diagnostic test. So most of the time we're using MIBG scans for primarily if it's a patient where we think they might need MIBG therapy, and then very rarely if other scans are inconclusive, particularly if it's a patient with we think they have pheochromocytoma, they have bilateral adrenal nodules, and the MRI really can't tell. And that's an area where dotatate PET really struggles and isn't helpful, and we do that sometimes. So there are rare other indications, but uncommonly. The one thing we can do that's really interesting with nuclear medicine that we can't do with other treatment options is something called dosimetry, where we have this companion diagnostic. So we can give a small dose of the treatment and actually take images of it over several days and measure in an individual patient how quickly that treatment is leaving the body, how much of it's binding to the tumors, how much of it's going to the normal organs that we worry about. And so these images aren't beautiful, but they're quantitatively very interesting in that we can measure and do regions and try to figure out how much dose can we safely give this patient. That's something that's done routinely with MIBG. It's not done routinely with most other treatments. It's really still, even though we've been thinking about it for a long time, it's been in the infancy. We're now starting to get some of the computer tools to make the calculations more robust and a little more straightforward. And so we'll see over the next several years whether this kind of personalization of the care, precision care, will become a more common thing. So MIBG therapy is the first and still the only approved treatment for pheochromocytoma and paraganglioma that needs systemic therapy. And just as Thor mentioned earlier, who needs therapy in patients with neuroendocrine tumors, including pheochromocytoma and paraganglioma, is a little bit different from a lot of cancers. So we know that these cancers, they develop at some point, and at some point when someone presents with disease all over the place, it came from somewhere, and people weren't born with this. And so you have that situation where you're walking through your bedroom and you stub your toe on the bed frame, can barely walk, you go to the ER and they do a CT scan of your belly, because that's what we do. And you find this, and our knee-jerk response is almost always, oh my God, look at all this stuff, we have to treat it. We have to pause and say, well, it got there at some point, but it might have been over the last 20 years. Or sometimes we see these things, they grow, and then for some reason they stop growing, and then when they feel like it, they grow again. And so we really do think about that. And our mantra at the Penn Neuroendocrine Tumor Program is it's a marathon, not a sprint. And so we try to think about how do we stretch things out, and we talk to patients like the sequencing question. We're not sure what the best order is, but we're pretty sure most everybody's going to get one of everything and then double helpings on a few of them. And so we think about that across the board. And so these MIBG scans, we're mostly doing them, for evaluating for therapy. With MIBG and occasionally with other treatments, sometimes the treatment has to be given in the inpatient setting. I mention this because there's a big disconnect between the way the regulatory documents read is everyone has to be treated as an inpatient unless they meet the criteria for outpatient therapy. Insurers think about it as everyone should be treated as an outpatient. And occasionally we have patients who can't be treated as an outpatient. We have to do it as an inpatient. It can be a little disconcerting. You have these rooms, they wrap everything with plastic. We do this to a lesser degree for the outpatient treatments, where the room, you'll see plastic on the walls sometimes, and these things on the floor to help prevent contamination with the radioactivity. One of the great things about radioactivity is we can detect it very well, so we can do those scans that are amazing. One of the banes of my existence is we can detect it very well. And so when you get a tiny little drop that doesn't mean anything and won't hurt anybody, once you know it's there, you really have to do something about it. So it's a double-edged sword. Usually for most of the drugs we use in most settings, we can do outpatient therapy, including with MIBG sometimes. Side effects with MIBG therapy, salivary gland pain is pretty common. It's typically short-lived, but patients tell me they feel like a chipmunk for a day or two. Nausea and vomiting is something that we see with any radiation. If you give enough of it, people get some nausea. And so we try to be pretty aggressive with treating that. Because MIBG, patients who need MIBG therapy often have blood pressure issues from their cancer releasing hormones to begin with. We can see that change, especially as the treatment starts to take effect and the patients don't need so much blood pressure medicine. We see the blood pressure start to drop, and we need to react to that as well. Blood counts is a common theme we'll see with virtually every radioactive drug, that's the symptom that we see universally, as blood counts drop. Most of the time, they don't drop low enough to where people are at risk for bleeding or infection, but it's something we keep an eye on. And I showed you that image where you saw some uptake in the thyroid gland, so the thyroid can become underactive late, pretty rare. And then we worry with any radioactive drug, and really most traditional chemotherapy agents that work by killing cells, they can, with enough exposure, cause cancers. And we worry about that. It is rare. It's something that we try to manage, and that's really the main reason, or one of the reasons, we don't treat until we need to. And we try to hold off on that. Moving on to the somatostatin receptor. So interestingly, somatostatin is a hormone that the body makes, and it can bind to any somatostatin receptor because that's what the job is. Somatostatin itself, like any hormone, hormones are used to turn things on and off very quickly. And so they're typically metabolized very fast in the body. So when your body makes somatostatin, it releases it, it immediately metabolizes it. It's around for only seconds. And so you couldn't make a really good imaging agent or a drug with something that's getting eaten up and chewed up and excreted very quickly. And so we've needed to make somatostatin analogs, so things that still bind to the somatostatin receptor but last longer. And that's octreotide was the first big one that was used as a therapeutic, and then also as an imaging agent, and now as a radiotherapeutic agent. But the somatostatin analogs, they don't bind as well to every single somatostatin receptor. So that's the first thing to mention, is there are some patients that, the ones that are out there, like octreotide and lanreotide, are designed to bind the best to the most common subtypes. So just because someone's somatostatin PET scan is negative doesn't mean their tumor doesn't express somatostatin receptors. It may just express one of the ones that doesn't bind as well with the agents we have. But subtype 2 is most commonly expressed. There are now 3 FDA-approved somatostatin PET agents. Gallium-68 dotatate was the first, then copper-64 dotatate, gallium-68 dotatate more recently, or DOTATOC, more recently. And there is plenty to worry about when you're a neuroendocrine tumor patient. And the one thing, if you take one thing away from this talk, I don't want anyone to ever worry about this. It really doesn't matter. So the imaging facility you go to may have a very good reason for which one they pick, and it won't affect anything. Even if last time you had one scan and this time you had the other one, it's not going to change anything, and so just please don't worry about that. The important thing is getting the scan when you need it, and not worrying about that one. Again, it is better in every way than the old Octrea scans, and so there's really no reason to do that anymore. We saw early after the approval that some insurance companies would pay for one and not the other, which was always insane because they cost about the same amount. But I haven't heard that in a while. And with gallium dotatate and DOTATOC, the half-life is only 68 minutes, so you need to be able to make it very close. And that could be a limiting factor for some places that are a little farther from a population center. But copper-64 dotatate can be shipped centrally from anywhere, basically to anywhere in the country. And so if there's a PET scanner, you should be able to get a dotatate PET scan or a DOTATOC PET scan. As far as the treatment, so it's interesting, PRRT was meant as a generic term, but it came to be synonymous with somatostatin receptor therapy. And so that's what we still talk about. Typically, it's an option that we think about in people who are progressing on somatostatin analog therapy. It's very, very rare that we'd be in a situation where we think about treating in someone who's never gotten a somatostatin analog, but occasionally it comes up. Most of the time, the patients who need systemic therapy early, where they need therapy early either before or concurrently with somatostatin analog, usually those situations are where we're thinking about chemotherapy. So very rare. But we always think about it in the context of the other options. We think about PRRT also in pheoparaganglioma. The one thing I'll caution you on, so MIBG is the first and only approved treatment, so there's just more, we have more data with MIBG in pheopara than we do with PRRT. So we think about that still as our first. we hear a lot of times people say, well, the dotatate scan was more positive than the MIBG scan, but that's sort of like, we've got the Art Institute just down the road here. If you went there and you could say it's more beautiful when I'm wearing my glasses than when I'm not. So it's, a lot of that is the modality, and that may go away if we do get those PET scans for MIBG. There is an ongoing trial at NIH, so if there is a patient with pheochromocytoma paraganglioma who can't get MIBG therapy, either their scan is negative or they just can't get it where they're at, we do really recommend patients consider trying to get to the NIH so that we can answer this question and really learn. Because it's such a rare disease, it's every opportunity is a good one. So side effects, there's quite a lot of overlap with MIBG, same thing with decreased blood counts. We worry a little bit more about radiation damage to the kidneys, which has been largely become a non-issue now that we have the amino acids. The amino acids themselves cause their own problems because there have been some supply chain disruptions, and they can cause some side effects on their own, typically nausea and vomiting. Fatigue is one that patients do complain of. I've completely given up trying to predict who's going to get bad fatigue and who's not. Some patients, the day after treatment, maybe they feel like, you know, yesterday was a long day, but otherwise they're fine, they worked full time. Other patients are just, they are wiped out for weeks after each treatment, and I don't know if you've had any better luck than I have, but I can't predict who it's going to be. Some patients sail through and some don't, and not a reflection on anything on the patient. Yeah. Yep. Different cycles. And so yeah, so we worry about that as well. Radiation safety is something that is important with these treatments. The one thing that I always try to get people to realize first is radiation is everywhere in the environment. So we are constantly, every minute of our lives, we're exposed to low levels of radiation. There's the sun, there's radon gas. When you take a flight, because you're up in the atmosphere, you get higher radiation doses than when you're on the ground. And we've evolved over millions of years to have ways to deal with that. So radiation in small amounts really doesn't cause us harm. And so what we want to do is minimize radiation exposure to people around you to levels that are similar to what people are getting anyway. And the bottom line with that is if you can follow the precautions, when they've done studies where they've put radiation dosimeter badges on family members and members of the public and things like that, the exposures to people have been way, way, way below what is allowed. And so that's really the take home is you really want to minimize time and maximize distance. It got a lot easier to explain with COVID, just do the social distancing and everyone gets what that means now. And if you do that, you're fine. The biggest hot button is avoiding contact with anything someone else may eat, because if you touch a computer or remote, while you might transfer a tiny bit of radiation to that, it's there, it's such a small amount, it doesn't amount to anything. But if you touch their sandwich and they ingest it, it's just going to hang around longer and amount to more. So that's the biggest thing that people can do to minimize radiation precautions. We recommend patients avoid pregnancy for at least 6 months after treatment. And the isotope and the amount that's given determines the duration of the restrictions. Because lutetium has less of that external radiation, less of those gamma rays than iodine-131, and they're of lower energy, typically the precautions are shorter and less strict. And that's why it can be done more readily as an outpatient. So frequently asked questions, so I'm going to jump the gun and answer a few of them that you may have, but one of the first questions I get, usually from patients who haven't gotten a single treatment, is, can I get this again? And it's like, well, let's get through it once first. But the answer is typically yes. If a patient benefits from treatment and their blood counts are still good, we do think about treating more than once. The data we have so far, and it's consistent across pretty much any treatment in any cancer, is if a treatment's effective and then something comes back and they need it again, usually it works up to as well, but it doesn't work better the second time around. It may have less of a chance of working and less of a duration of effect. And so that's why we think about other trials like the alpha PRRT, which is something that comes up a lot. My primary research interest is in alpha emitters, and that's what I spend most of my lab work doing. And so I'm really enthusiastic about alpha particles. They're not magical. So we hope that they'll be better, or at least as good, and they have certain advantages, but they're probably not going to be just like perfection. And so I like to tailor people's expectations. And they're still investigational at this point. And so we do research because we want to answer a question, and that implies that we don't know ahead of time what the answer is. We think we do, otherwise we wouldn't do the trial. But even the best intentioned and most exciting trials, sometimes at the end of it we get a negative trial where what we were testing doesn't turn out to be better. And then obviously, where do radiopharmaceuticals fit in with all the other options? And that's why we have a tumor board. I really echo what Thor was saying, that these are multidisciplinary conversations. Every patient's different, and there can be really subtle but important reasons why we might swap around the order in different patients. And I will stop there. Thank you very much.
I'm probably going to break every rule in the house and touch the cameras in a second, so maybe I'll try to do it this way. Why don't both of you sit down?
Okay.
Try this side, because we're still recording, and I'm going to just screw with their equipment. Yeah, that's good enough. So I'm going to get long enough? Yeah, I am. Sorry for that bump there, guys. But now we have a podium mic. All right, so some questions. If you have any questions that are going on, please feel free to come up in the microphone. You did answer a fair amount of the questions that come up. One that comes up is, can I do more PRRT post having 3 or 4 rounds? I know, Thor, you're working on a clinical trial. I think are you on that clinical trial as well, for the repeat trial? Okay, there is a trial that's just starting up in the NCI that's called Repeat, which is looking at 4 more rounds of PRRT post the first 4 rounds for those who have been stable for after that. I'm fine. It's when I pass the mic whether they'll be fine. Other questions that anyone else has from the room? I know one of you had a question on traveling post-PRRT. Thor, we did a paper on that. Do you want to summarize?
Sure. So just a little bit of a background there. So I practiced in Minnesota. Previously, I practiced in Arizona. So one of my patients said, I'm actually going to, in the 8 weeks between the PRRT treatments, I'm going to go to Canada to go fishing. And then as he's entering the U.S., he's pulled over, like even before he gets to the border station, they pull him over and said, "You're hot." And I said, "Yeah, I knew that." So he's a funny guy. And they said, "You're really hot. You're setting off all of our meters." And so what happened is that he was 4 weeks post-PRRT, and the radiation, residual radiation, was actually detected by the Homeland Security detectors. Around the same time, my colleague in Arizona had the same thing happen in a patient coming in through Yuma. And so we obviously, the first thing we did, we said, we got to call Josh, so see if he knows anything about this. And obviously he does. And there is, the reason for this, I think I explained this right, is that that little residual radiation, which is not harmful, reads as plutonium on the Homeland Security detectors. And it can last for, I don't know how, 4 or 6 weeks.
Yeah, no, actually, specifically lutetium-177 has the same spectrum, very close to plutonium, so that's why people get stopped who are having Lu-177 or can get stopped, and it actually lasts for 10 half-lives, which is 67.7 days, a half-life being 6.7 days, so it's going, and this changes depending on what you're having and whether the isotope or whether they pull you over. So for those of you who also live in New York or near sensitive infrastructure, they have these things set up before bridges entering Manhattan. You can get pulled over, things around Washington, D.C. There will be people set up with, and sushi restaurants in Oakland apparently, because after my last treatment, I lived 2 miles away from the Port of Oakland, and about 4 weeks after my treatment, I was actually at a sushi restaurant with my wife, and one of the custom Border Patrol agents, and it's not TSA, it's Border Patrol, they were actually at the sushi bar, and their alerts started going out, and they were freaked out and started asking the wait staff, were they microwaving metal or something, and I had to wave. But it's all good, and what you need to do, the other thing of the paper is be very slow, be very deliberate, let them know you've had medical treatment, let them know what the isotope is. Some places give wallet cards, others will give letters. Don't reach for anything quickly, very slowly, if they would like to have the documentation. But some of them will just take it from you, your word, and go look it up and scan you and send to the Office of Medical Teleforensics, which is who will clear you after that. So I'm going to ask a question that involves both of you. Dan, you're excited about alpha, which I think is fantastic. And you know, Thor, you're currently treating and looking at putting people in clinical trials. As a patient, when we come to you and say, gee, and there's a clinical trial about to open, we're going to have an LU-177 retreatment trial, we're going to have alpha, we have other choices. When there's multiple choices, we have 2 alpha trials going on. What are the things patients should look for to make the decision of what to do? Because you know, we haven't been studying alpha since we were in graduate school, and we haven't been looking at each one of these documents. So how are we supposed to make that decision?
So I guess the first question is, should I go on a trial or should I get a standard of care treatment? And we really think about clinical research as part of clinical care in cancer, and really the best clinical care. And so thinking about it in that context, that they are options, and typically, especially if it's a late phase trial where you're comparing to the standard of care. And so it's an opportunity, and like I said, we don't know what's going to happen, but we have reason to think that it may be advantageous to the patients. If there are multiple trials that you're eligible for all of them, I think then practical considerations come into play. An open trial. I'll give you a secret, is the trial is nearly open, could mean next year. And so an open trial is definitely an advantage. A trial you have with a doctor you're comfortable with, a place you can get to easily is very helpful. And so asking those questions about how many visits, if it's a trial not near home, is there support for the travel? Because it is, like I said, it's very thorough care you get on a clinical trial, but it's a lot of care. And there's a pretty strict schedule of events, and we need to stick with that. And so I think looking at that in the context of what else you have going on in your life.
So before Thor, do answer that, but I want to just remind people that what Dan's describing is there's usually a schema or grid of information that you'll get to plot out what all the what you're required to do in the trial, so that you can know how many days you're spending, how those days line up, what your responsibility is, and it's in something called the informed consent. And really do read it and read that grid. I have co-authored 1 or 2, and I help train physicians to write them. So it's really important that you actually use them, because we really do a lot of work to make sure they don't take you in too many times. Thor?
So not much to add, but it's as for like the PRRT retreatment. So we have done that for a number of years, and there are some data. And now we have 2 different clinical trials. One is looking at the retreatment with lutetium-177 dotatate. Another one is looking at an alpha particle actinium-225. And we just had to make a choice at Mayo. We said we probably cannot open both. It's just we don't have the staffing for it. So we picked the one that was more novel, figured that that would be the one more likely to advance the practice, but we may be wrong. So, and we figured we can always offer the lutetium off-label, so outside of a trial. Ideally, I would have wanted to open both.
Yes, but it would be great to have the final answer. with why we do trials, right?
And I don't know, I would have liked to see a study comparing these two.
With that, is there any other questions from the audience? I know I got peppered with a few while we were on our walking tour. Have we not covered anything?
I'm just curious, after you have PRRT, when is the right time to have rescan to see results?
Oh yeah, this is a controversial topic. Well, you know, one, is there a perfect scan post PRRT and post Lutathera? Should that be post all treatments or in between, or how do you determine when it's important to get in between treatment scans, and what's the correct modality?
Yeah, and
And how soon before PRRT should we stop the laboratory?
okay, so I'll leave that one to Thor. So as far as scanning, we do everything we can to not scan during PRRT, just because it can cause things to swell up. It can be, it can just lead us down the wrong path and is rarely helpful. Having said that, if we see any signs that someone's not doing well, something just doesn't seem right, we won't hesitate to scan, but we don't plan to scan during treatment. We typically will do the first scans, I say 6 to 12 weeks after the last cycle. Well, we open negotiations at 12 weeks. Usually by the patient hasn't had a scan for like 6 months, and a lot of our patients are a little antsy to see what's happening. So we typically end up, it's a little sooner than that, more like 6 weeks after. And we typically will scan with whatever they had anatomically before treatment, so either CT or MRI. We try not to use dotatate PET for the treatment response. It's not, I don't find it as useful in terms of being able to do the measurements. But what I tell patients is we'll do a scan, like I said, 6 to 12 weeks later, and then we'll do another scan about 3 months after that. And the next scan almost always looks better than that first post-treatment scan. So I just want people to have their expectations set. If the scan looks absolutely no different from before treatment, that's a great thing. And sometimes it may even still look, things can swell up, and so it can be unclear. So we don't really know the final answer until 6 months, 9 months later.
When we do talk about swell up, and I'll get to the Lanreotide thing in a second. When we do talk about swell up, what's the, you know, also progression is swelling up. And in the last paper I read on this, it was a little bit, about 30% have pseudoprogression, the swell up, and then 12 to 15% actually have real progression. So when you say swell up, something that would do pseudoprogression, how as your radiology team would you read that? Is that tumor jump 50% or it jump 20%? Or are there some characteristics where we can be confident as patients that you're able to say, that's pseudoprogression, we're cool, versus that's really progression, and it's a long time since you've been on other treatment, we got to get going.
Yeah. And it's not a very satisfying answer, but the best way to tell that is time, which is a super stressful answer to say like, oh, we'll repeat the scan in 6 to 12 weeks. But it can be really, really hard.
Thor?
Yeah, so that's how much is how much is much. So it's so sometimes you actually get a clue just looking at the contrast images. So sometimes you see there's a little bit of swelling in the tumor, but now there's a lot less blood flow in the center of the tumor, and then we think, hopefully correctly, that we're actually seeing a treatment response. The first patient I ever referred for PRRT went to Switzerland. This was back when I was at the University of Iowa. First scan after PRRT, tumors grew. So I called Switzerland and they said, don't worry, just wait. And the next scan, things grew a little bit, not as much as before. And we're talking like tiny little changes. And then like the 4 next scans, everyone was smaller than the one before. So sometimes you just have to wait a little bit. So one of our trainees looked at the scans that we did before the 3rd cycle. So she looked at about 100 treated patients. And that scan done before the 3rd cycle almost never changes anything we do. So we haven't, so probably okay to omit that one. And that's what we're increasingly doing, just like you.
The last one was when to discontinue Lanreotide prior to.
So typically 4 weeks before is what we do, and it's a very interesting question. But 4 weeks before is, and the short-acting octreotide stop it 24 hours before.
Last question.
Yes, hi. I'm sitting here listening at
So question one is the VA involved in clinical trials or just in research? Certainly. We have several of our, in nuclear medicine, we have several members that are part of the VA and certainly do on research. Tom Hope actually is attending at the VA, which is the UCSF. Some of them have split. I know there's one from UCLA whose name I'm blanking on right now, but there are several in the VA who both do clinical work and clinical research.
Yeah, and not many of the VAs, to my knowledge, have a neuroendocrine tumor sort of a clinic. So I actually worked at the Iowa City VA for 5 years, and we had the neuroendocrine tumor clinic there. So, and that's just because we were across the street from University of Iowa. It has one of the largest NET clinics in the country. So, and some of the nuclear medicine people are actually primarily on staff at the VA. But the VA is increasingly getting involved in research. I've been out of the VA now for more than 10 years, but there's a lot of room for improvement, getting trials to veterans, and it was when I was doing this it wasn't easy.
But trials that are available and pharma sponsored usually are available for people who aren't going to that particular center as well. So.
Correct. So that's what I was going to add,
Yeah.
is that if there's a trial, even as a VA patient, you should be able to go to virtually every VA is affiliated with a medical school. Yeah. And the other thing is the VA can be a little bit difficult to navigate, as you know, but if there's a treatment or a scan or something that they don't offer that's standard of care, they will pay for it at a place. So it's worth learning that paperwork, but it's a struggle.
So with that, I want to give our speakers a round of applause. I want to give you guys a round of applause because you hung out all day.